Hey, welcome back. We're going to go ahead and move forward. And now we're going to start talking about how we approach the patient who has HER2 positive cancer in the early stage adjuvant setting. Okay. Again, just to reorient ourselves, the patient had a diagnosis. The diagnosis of the lesion, it was proven to be cancer. The cancer was interrogated and revealed that it was HER2 positive. The cancer was small enough such that a breast conserving procedure could be performed. A lumpectomy was done, and now we have to make a decision on what we do in the adjuvant setting. This time, the cancer is HER2 positive. So what do we do here? Well, for HER2 positive cancers, what the studies have suggested is that the best approach in the adjuvant setting is to combine chemotherapy with some form of HER2-directed agent. And when we talk about HER2-directed agents in this setting, we're really talking about the administration of a drug like Herceptin or trastuzumab. It's a monoclonal antibody that targets the HER2 protein. On occasion, in the early stage setting, you may combine trastuzumab with an additional monoclonal antibody that you've heard of called pertuzumab or Perjeta. And there's some stratification of patients that helps you decide whether or not to do one or both, right? But regardless, HER2 positive in the adjuvant setting equals chemo plus monoclonal antibody. We never use monoclonal antibodies by themselves in the initial stages of a regimen. It's always combined with chemo. And then after the chemo cycles have gone in, then we can de-escalate and use the monoclonal antibody to round out a specific time period for the adjuvant treatment. And we'll mention that in a little bit. Okay. All right. So what do? We use HER2-directed therapy with trastuzumab and pertuzumab, perhaps. And what do we combine the antibodies with? Well, we can use a taxane like paclitaxel. There is a regimen that involves the use of paclitaxel and trastuzumab in the adjuvant setting. However, this particular combination is typically only reserved for low-risk patients. These are patients that have very, very small tumors with no nodal involvement. All right. So you have a subset of the population that might be amenable to this particular regimen of the taxane and trastuzumab. But I'm going to be honest with you. I think there isn't a lot of data out there on small tumors like this. And the likelihood of finding one being HER2 positive is kind of, I don't want to say it's rare or impossible, but it just doesn't happen as often as you'd like, right? So if you were to find a lesion incidentally during screening mammography and you caught it early, maybe that patient's a good candidate for this particular regimen. But how old are they? What's their ECOG score? And are they going to tolerate perhaps a more aggressive adjuvant regimen, such as the TCH regimen? So TCH, what does TCH really stand for? Well, in essence, it's referring to a taxane, Taxotere, or docetaxel, carboplatin, and then trastuzumab. So this is taxane and platinum agent combined with monoclonal antibody. And this is a regimen that gets regularly used in both the neoadjuvant and adjuvant setting for HER2 positive cancers. The minute, though, that you start seeing nodal involvement, the minute it goes from N0 to N1 disease, or the tumor increases in size on diagnosis, that may call for the addition then of trastuzumab plus pertuzumab. And what we end up with there is a regimen called TCHP. So it's the taxane, the carboplatin, trastuzumab, and pertuzumab. We add on pertuzumab here because of the nodal involvement or the larger primary tumor. right? And the studies have shown that adding pertuzumab to that regimen, right, has a benefit, has a survival benefit. I think it was the Affinity trial that actually proved that. All right, so again, this sort of breaks it out for you with regard to what the preferred regimens are from the guidelines. This is HER2 positive cancers, right? And I'm going to draw a line right through here, right? And this top part, all right, is really showing you what you could do both in the neoadjuvant and adjuvant setting. We're focusing right now on the adjuvant setting. So we can use any of these in the adjuvant setting for the early stage disease, right? Now, on occasion, you might find that a patient has a unique circumstance, and maybe we're jumping ahead a little bit too much, but I'll just make mention of it right now because we're going to see this again. HER2 positive cancers, if you recall, they're more aggressive. They grow faster and they have a propensity to spread. Okay. And unfortunately, sometimes by the time they're diagnosed, the patient doesn't necessarily qualify for these lumpectomies. The tumor is so large that they might have to do what was referred to as neoadjuvant treatment. So we can use a regimen like the TCH or the TCHP regimen in the neoadjuvant setting. Then you go in and do the surgery. And then when you open the patient up to investigate the area where the lesion is, if there is no residual disease, if all the cancer has died and there's only some necrotic or scar tissue there, recall that's called a pathological complete response. And that's what you hope for. All we need to do at that point is just clean up the area, and then we can start the patient on the adjuvant therapy. However, sometimes that patient doesn't respond like you want, and they have residual disease despite the neoadjuvant regimens. There's other drugs that we can use then at that point to help sort of clean up leftover cancer that might still be there. Okay. All right. Paclitaxel, trastuzumab, or the TCH regimen, Taxotere, carboplatin, trastuzumab, or TCHP, where you add on the pertuzumab. There's one interesting and important characteristic about those regimens. Those preferred regimens are all anthracycline sparing. In other words, there is no doxorubicin involved in those regimens. And that's important because the trastuzumab by itself can induce some cardiac toxicity. It can be cardiotoxic and reduce ejection fraction. Doxorubicin, of course, has cardiotoxic effects as well. And prior to the trials showing that TCH and TCHP were so effective, we were using a regimen called ACTH. And that was an anthracycline and cyclophosphamide, followed by a taxane plus Herceptin. And those combination of drugs really took a toll on the heart. You're subjecting the patient to an anthracycline for several cycles, and then you're backing off the anthracycline and starting the Herceptin, which is cardiotoxic. So we don't use that regimen too much anymore because of the risks associated with the regimen. And we like these other regimens here because they are anthracycline sparing. The other thing to note is that if a patient got TCH or TCHP in the adjuvant setting and then they had a progression, well, now you know you have an anthracycline in your back pocket to perhaps pull out if needed. Okay. All right. So I talked a lot on this slide, but what do I really want you to focus in on? HER2 positive, adjuvant setting, early stage. I want you to be familiar with when you would use that regimen, and then when you would use either of those two regimens. Okay. Trastuzumab and pertuzumab dosing, again, too, there's some figures in here that I can show you that spell out the dosing for you. It's weekly or every 3 weeks. And what's important, though, is the duration of this adjuvant therapy, right? We give patients in the adjuvant setting a total of 52 weeks of anti-HER2 antibody therapy, okay? A year's worth of monoclonal antibody. They'll get, if surgery is at this point, after surgery and recovery, we start the chemo plus the monoclonal antibodies, and we'll do that for maybe 6 weeks, 4 to 6 weeks, depending on the regimen. And then after that, we continue the monoclonal antibody, right, for an additional, what would that be? 48 weeks, maybe, to give you at least 1 year of monoclonal antibody treatment, all right? If you started on both, you continue both. If you started on trastuzumab, you try and continue trastuzumab. If you started both and the patient can't tolerate both, and the pertuzumab is creating so much diarrhea that it's offensive and dangerous, we can drop the pertuzumab, right? We do see a reduction in left ventricular ejection fraction with trastuzumab, so we have to monitor that. We get a baseline ejection fraction, and then we follow it during the course of therapy and then several times after therapy is done. And when we start to see decreases in ejection fraction, then that might trigger some type of alteration in the therapy. Maybe we have to hold a dose, maybe we have to discontinue it altogether, depending on how severe the decrease is. Monoclonal antibodies are notorious for causing infusion-related reactions, right? The definition of an infusion-related reaction, it depends on who you actually talk to, but it could be something as mild as chills, a fever. It could cause some itching. It could be more severe where the patient's starting to have difficulty breathing. So there's a lot of different signs and symptoms that could indicate an infusion-related reaction, and maybe I'll get you guys something specific. Skin rash, not uncommon. That can happen. Again, headache, insomnia, pain, chills. All of this can be and is associated with the infusion of a monoclonal antibody like trastuzumab or pertuzumab. I promised some dosing. You will not be asked this on an exam, and chemotherapy is something where you double and triple check the doses all the time. It's built into the workflow, or it should be. Technician prepares the chemotherapy. Pharmacist number 1 goes in and checks the order. Pharmacist number 2 comes in and verifies it yet again. All right. Sign it, send it. HER2 positive preferred regimens. I mean, if you were giving somebody the paclitaxel and trastuzumab regimen, that TP regimen, I think is what it's referred to as, 80 milligrams per meter square of paclitaxel weekly for 12 weeks with the trastuzumab. Okay. TCH or TCHP shown here as well. And you can see these cycles these therapies are done for at least 6 cycles, 6 cycles of chemotherapy. But the trastuzumab is 1 year. 1 year. All right. HER2-directed therapy. That is the gold standard right now for HER2-positive tumors. There is a scenario where a patient might present with what we refer to as triple positive breast cancer. Here, the tumor has revealed that it's overexpressing both the estrogen receptor and it is HER2 enriched. What do we do in this scenario? Well, we know that in the adjuvant setting for hormone receptor positivity, we use endocrine therapy. We know that in the HER2 positive setting, we use HER2 directed monoclonal antibodies, and we do this with chemo initially. So it stands to reason if you've got a patient with triple positive disease, the combination of chemo plus a monoclonal antibody and endocrine therapy may end up being the standard of care. So let's break this down a little bit. Let's pretend for a moment that we have an individual who has a relatively small tumor, less than or equal to half a centimeter, and has no nodal disease. This is a caught early, relatively low risk. I will tell you that this is an area of uncertainty because there's not a lot of data surrounding this particular type of patient, or even the patient that has some minimal cancer involvement in one of the nodes. We don't have a lot of data on what to do with these individuals. So adjuvant endocrine therapy with or without chemotherapy and trastuzumab is a discussion. Right? The endocrine therapy is probably going to be yes, absolutely. Where we're uncertain is whether or not we add on chemotherapy plus trastuzumab. It's a 2B category, suggesting that it's not really strong evidence backed by randomized controlled trials. Right? So fortunately, we don't encounter a lot of people like this, even though we would like to. Opposite to that, maybe we have a tumor that is 0.6 to upwards of 1 centimeter in its greatest diameter. What's recommended here, based on the size, is adjuvant endocrine therapy or adjuvant chemotherapy plus trastuzumab, then endocrine therapy. That's a little bit more aggressive. Right? It's HER2 positive, it's hormone receptor positive. The chemotherapy plus trastuzumab makes sense because HER2 positivity can portend a poor outcome later on in life with regard to recurrences. It's hormone receptor positive, so endocrine therapy makes sense because, well, we saw the data on endocrine therapy in HER2 positive disease. Now, combining both of them, that's going to be aggressive, and that probably will generate the outcomes that you're interested in and outcomes that you want. But is your patient a candidate for that aggressive approach? If they are and they can tolerate it, it's probably a good recommendation. If your patient has comorbidities or cardiac disease or some type of circumstance that might predict a poor outcome with the adjuvant chemo and trastuzumab, maybe you just opt for the endocrine therapy alone. And lastly, if the tumor is greater than 1 centimeter, all right, that's already considered, I don't know, necessarily think it's a large tumor, but it's large enough to warrant the combination of the chemo and trastuzumab followed by the endocrine therapy. That's a category 1 recommendation, and there is data out there to support that treatment approach for individuals with a larger tumor, right? So that was pretty much for individuals with no nodal involvement or minimal nodal involvement. Individuals that have positive nodes N1 disease, adjuvant chemotherapy with trastuzumab and endocrine therapy is recommended. And in fact, adding on pertuzumab to the trastuzumab and chemotherapy ends up being a preferred approach, right? In addition to the endocrine therapy. So this particular box here carries with it increased risk. And because of that, we're going to do something like TCHP, right? And then after we do TCHP, they're going to get endocrine therapy as well. Pretty aggressive. Right. Okay. Before we jump into triple negative disease, let's just